Hello friends, today video is about hepatorenal syndrome. I am Dr. Arun Kumar. Welcome to Medical Guruji. Let's start with introduction. Hepatorenal syndrome is a severe and life-threatening complication of advanced liver disease characterized by functional renal failure in the absence of identifiable structural kidney damage. It carries a high mortality rate and poses a significant challenge. In this video, we aims to provide a comprehensive overview of hepatorenal syndrome covering its pathophysiology, clinical presentation, diagnostic criteria, and different management strategies. Coming to pathophysiology, the pathophysiology of hepatorenal syndrome is a complex and multifactorial, but it primarily revolves around extreme renal vasoconstriction due to circulatory dysfunction in the setting of severe liver disease. Key factors include portal hypertension, that is increased pressure in the portal venous system that lead to splanchnic vasodilation and reduced effective circulating volume. Next is arterial vasodilation. Systemic vasodilation, particularly in the splanchnic circulation, is triggered by nitric oxide and other vasodilators, further exacerbating the decrease in effective circulating volume. Next is activation of vasoconstrictor systems. The renin-angiotensin-aldosterone system, that is RAS system, and sympathetic nervous system are activated in response to decreased effective circulating volume that lead to intense renal vasoconstriction. Next and last is reduced renal perfusion. The combination of systemic vasodilation and renal vasoconstriction result in decreased renal blood flow, that is glomerular filtration rate (GFR), ultimately leading to the functional renal failure. Now, hepatorenal syndrome is mainly classified into two types. First one is HRS-AKI, that is hepatorenal syndrome with acute kidney injury, that is type 1, characterized by a rapid decline in renal function with a doubling of serum creatinine to more than 2.5 mg per deciliter or a 50% reduction in creatinine clearance within 2 weeks. It often follows a precipitating event such as spontaneous bacterial peritonitis (SBP) or gastrointestinal bleeding. Second type is hepatorenal syndrome associated with CKD, chronic kidney disease. This is type 2. It is characterized by a more gradual decline in renal function with less severe renal impairment. It is often associated with refractory ascites. Coming to clinical presentation of hepatorenal syndrome, it typically occurs in patients with advanced cirrhosis and portal hypertension. Common clinical features include oliguria, that is decreased urine output, azotemia, that is elevated blood urea nitrogen (BUN) and creatinine levels, hyponatremia, that is low serum sodium levels, ascites, that is accumulation of fluid in the abdomen, jaundice, this is yellowing of the skin and eyes, and hepatic encephalopathy, that is altered mental status due to liver dysfunction. Coming to diagnosis, the diagnosis of hepatorenal syndrome is based on clinical criteria as there are no specific diagnostic tests. The International Club of Ascites (ICA) criteria for hepatorenal syndrome include advanced liver disease with portal hypertension, renal dysfunction, that is serum creatinine more than 1.5 mg per deciliter, exclusion of other causes of renal dysfunction, that is no proteinuria more than 500 mg per day, no microhematuria, and normal renal ultrasound. No improvement in renal function after diuretic withdrawal and volume expansion with albumin. Management of hepatorenal syndrome is challenging and it requires a multidisciplinary approach. Some key strategies include medical therapy, including vasoconstrictors, that is terlipressin, midodrine, or octreotide, which are used to counteract systemic vasodilation and improve renal perfusion. Second is albumin, that is used for volume expansion and to improve circulatory function. Third is transplantation of liver. This is the only definitive treatment for hepatorenal syndrome as it is a complication of liver failure or due to the cirrhosis of liver. Next option is transjugular intrahepatic portosystemic shunt, that is TIPS. It may be used as a bridge to transplantation in selected patients. And last is renal replacement therapy. It may be necessary in severe cases to support the renal function. Prevention of hepatorenal syndrome. focus on early recognition and management of precipitating factors such as spontaneous bacterial peritonitis and gastrointestinal bleeding. The use of albumin in patients with spontaneous bacterial peritonitis has been shown to reduce the incidence of hepatorenal syndrome. In conclusion, hepatorenal syndrome is severe complication of advanced liver disease with a high mortality rate. Early recognition, prompt diagnosis, and timely intervention are crucial for improving the patient outcomes. A multidisciplinary approach involving hepatologist, nephrologist, and critical care specialist is essential for optimal management. Thank you for watching the video. If you like the content, then subscribe our channel, share the video, and stay tuned for more knowledgeable updates. Thank you.